Welcome to everyone. Thank you for joining us this evening. This is the new Grand Challenges Forum. We have changed our format and we have moved to 6 in the evening from 6 to 7. We will have an awesome lecture and discussion, questions and answers to come later. And so we are glad that you have joined us this evening. I wanted to just ask that everyone turn their viewing option to the speaker view, and that will give you the optimal experience here tonight, okay? So we will turn this over to Dean of the Honors College, Dr. Bill Monroe.
Thank you. Thank you so much, Christine. As Christine said, changed the Grand Challenges Forum, and we're actually branding it as the new Grand Challenges Forum, not only because in a Zoom format for obvious reasons, but also because we're being more intentional, more timely, and we hope more connected to both our campus and our world. We think of the Grand Challenges, the new Grand Challenges Forum, always have as a bridge, one of the many ways that we can connect town with gown, our city with our courses, our students, our faculty and staff. So thank you for being a part of this inaugural event. This is, I think, our 5th year of doing the Grand Challenges Forum, and we will get back to in-person when we can. But for now, we're quite happy to have this format, and we're very happy to have our guest this evening, Dr. Ricardo Nuila. Dr. Nuila is an attending physician and hospitalist at Baylor College of Medicine, where he teaches the practice of internal medicine and medical humanities. As a faculty member in the Center for Medical Ethics and Health Policy, he directs the program of narrative medicine. And until 2017, shortly after his first child was born, Dr. Nuila taught literature and medicine and narrative medicine classes for the Medicine and Society program, faculty member in the Honors College. Ricardo attended Strake Jesuit here in Houston and earned a Bachelor of Arts in English at Georgetown University. His essays on medical ethics and health disparities appeared in the New Yorker, the New England Journal of Medicine, and the Virginia Quarterly Review. He is also a fiction writer whose stories have been published in Best American Short Stories 2011 and multiples, including McSweeney's and the New England Review, which awarded him its inaugural 2015 Emerging Writers Award. The Texas Institute of Letters and the University of Texas selected him as the J. Frank Dobie Paisano Residential Writing Fellow for fall 2017. Ricardo, we're delighted to welcome you back to the Honors College and the University of Houston.
Thank you so much, Bill. I love the Honors College. I'm very honored to be here, especially for the Grand Challenges Forum. I'm constantly going through Grand Challenges, as evidenced right here by this cut here. I wish I could say that that was a result of UFC 252, Overeem versus Miocic. Oh no, I mean, one of the heavyweight title fights, but my 4-year-old hit me. My 4-year-old just crapped me right here yesterday. And I will tell you this, parenting is one of the greatest and challenges that I've ever encountered. But so it is a grand challenge. I'm thinking of grand challenges, and as much I just love being here with the Honors College, and just going to go right to it. I know that you know, we're all living through the pandemic, and we're all trying to figure out what's the best step forward. And so I'm going to just open up by just reading one of the essays that I've written that appeared, the one that I've written most recently, actually, that appeared on the New Yorker website. Bill asked me to read this because I think that it's timely enough that it applies to all of our lives, but I think that I learned a lot while writing it. And so I'm just going to read it for you all right now. And I look forward to any questions and a discussion that we could have about grand challenges or anything that comes out of this piece. So the piece is called, and it was published on the July 17th, 2020 on website on that day. The piece is called, "To Fight the Coronavirus, You Need an Army." On June 24th, as Texas was beginning to reckon with its dramatic spike in coronavirus cases, I received a phone call from an alarmed friend. He'd heard a rumor about Houston's Ben Taub Hospital, where I work as an internist. Apparently, it was so full of patients that some seeking treatment for COVID-19 were lining the hallways, while others had left after spending too long in line. "Do we have a New York situation on our hands or what?" he asked. I'd been working at the hospital for 4 weeks without a break. The stress on the system was evident, but I hadn't seen anything like what he described. "We're busy, but it's not chaos," I said. Still, I was unnerved, and after hanging up, I took a walk around the hospital to make sure I hadn't missed something. The emergency room and its waiting area were orderly and nearly empty. At the triage station, a single patient wearing a mask stood calmly while his blood pressure was being taken. I greeted the nurses on the medical surgical units. "How are y'all doing?" They seemed overworked, but in control. In the ICU, doctors in gowns clustered around computer workstations, rounding as they normally did. It was hardly a scene from a disaster film. In one hallway, a set of flat-screen televisions explained what I was seeing. They showed the capacity levels of hospitals across Harris County, which includes Houston. The county as a whole was on the edge. Of its 1,614 ICU beds, 1,509 were full. Around 500 of those patients were sick with COVID-19. The rest suffered from the mix of conditions that were typical before the pandemic. Ben Taub Hospital, I saw, had reached saturation, which meant that incoming ambulances were being diverted elsewhere. The grim statistics contrasted oddly with the calm atmosphere surrounding me, but also made sense of it. My hospital, evidently, was saturated and empty at the same time. I've since learned that this situation isn't unusual at overburdened hospitals during the pandemic. Earlier this spring, when I first began worrying about whether Houston had enough resources to handle a spike in infections, I thought mostly about equipment and space. I counted our hospital's ventilators and negative pressure rooms, taking the concept of an ICU bed literally. Now I understand that Houston, a first-rate medical city, doesn't lack space or equipment. If our hospitals can't accept more patients, it's because we don't have enough ICU nurses to care for them. Our scarcest resource is human. In late March, patients with COVID-19 started arriving at my hospital. To avoid exposure and conserve PPE, I treated my first patient with the virus mostly from the hallway, calling him on the phone. The nurses took a different approach. "We're in there all the time," one told me. Day and night, she and her colleagues were checking his vital signs, helping him use the bathroom, and addressing the alarms emanating from the medical devices surrounding him. At that point in the progression of the illness, they were doing most of the work that COVID-19 required. My only job was to see whether the patient's breathing was improving. When he left the hospital, fully recovered, I was happy but not proud. I had little reason to be. The victory belonged to the nurses and respiratory therapists. In the treatment of virtually all diseases, the number of personnel needed increases as the level of care escalates. For COVID-19, The most basic level of care involves a nasal cannula, a forked tube leading from an oxygen tank into the nostrils, which delivers about twice as much oxygen as is contained in ordinary air. On the medical surgical wards where such devices are used, a single nurse can oversee the care of 5 patients. But people with more advanced cases of COVID-19 have fluctuating oxygen levels and more extensive needs. Respiratory therapists must visit at least once every 6 hours. Doctors must order more frequent blood draws, vital sign checks, and heart monitoring. In the intermediate care unit, where patients like these are treated, the nurse to patient ratio is 1:4. In the ICU, where patients receive an even higher level of attention and care, each nurse can work with only 2 at a time. Often, many people must converge to offer care simultaneously. Proning, which has emerged as a valuable therapeutic advance in the treatment of severe COVID-19, is a good example of work-intensive ICU care. A patient who is proned is flipped from her back to her belly while her breathing tube, IVs, and monitors are kept intact and attached. Many hours later, the move must be reversed. During the pandemic, proning has been shown to make a life-saving difference for some patients. It allows the fluid in the lungs to redistribute itself, opening up new areas to oxygenation. But carefully flipping an unconscious, paralyzed patient can require as many as 6 people, nurses, assistants, therapists, and sometimes doctors, each gowned in PPE, to coordinate their efforts, as though they are moving a large sculpture. In order for an ICU to prone large numbers of patients each day, it must be fully staffed. Staffing, therefore, shapes ICU capacity just as much as equipment. Not long ago, I received a phone call from a nurse who was caring for a patient of mine. We suspected that she had COVID-19, and though her vitals weren't necessarily concerning, she wasn't looking great. Within half an hour of my arrival at her bedside, she had been intubated at my request. Our ICUs were full, meaning that the ratio of nurses to patients there was holding steady at 1:2. But the critical care team and the hospital's nursing leadership were able to accommodate her, finding not just a room where she could receive ICU level care, but also a dedicated, trained nurse. I recalled something Ismail Porsa, the chief executive of Harris Health System, had said in an interview. If somehow, magically, there's a group of 10 or 20 ICU nurses that I can have, then I can transform more of my beds into ICUs. But there are rarely extra nurses to be found. And so a COVID-19 spike ends up diverting staff from the hospital as a whole. At Ben Taub, nurses have been moving from the medical surgical wards to intermediate care, or from intermediate care to the ICU. Similarly, internal medicine doctors like me, who are used to seeing patients in medical surgical units, have begun working in ICUs under the supervision of critical care doctors. The ratio of nurses to patients in the ICU has occasionally climbed to 1:3 or higher. Meanwhile, the need to stretch personnel trickles down. A nurse on a medical surgical unit might now be responsible for 8 patients instead of 4, a lower ratio that increases risks. Nurses aren't interchangeable. Many have extensive training and experience in specific areas, such as post-anesthesia, labor and delivery, or burns. Last week, as the number of new coronavirus cases per day in Texas passed 10,000, and as ICUs across Houston grew even more saturated, I called up a former ICU nurse I know who now works as an administrator at a large private hospital near mine. I asked her how the nurses there were doing, "We are not okay," she said. Under the pressures of the surge, the nurse-patient ratio in her ICU was regularly being pushed to 1 to 3, and many nurses were working 6 12-hour shifts each week. With more COVID-19 patients coming in, the hospital had opened pop-up units, which had stretched nursing ratios further. "People think a nurse is a nurse is a nurse, but they are just as specialized as doctors," she said. In patient care, nothing is as stressful as having to learn new tasks and replicate them quickly. Many nurses were showing signs of burnout. The farther one travels from Houston, the more easily one finds hospitals struggling with ICU staffing. On a recent morning, when I called around, I found that 6 ICU beds sat unused for lack of nurses at a hospital in Richmond, 30 miles from downtown. 45 miles further down I-59, Frances Lerma, the head of nursing at El Campo Memorial Hospital, told me that she hasn't had the time to uptrain her staff. Instead, she relies on their adaptability as she transfers them to COVID-19 care as quickly as possible. By settling in El Campo, a city of 12,000, Lerna had figured that she'd be taking a break from the strenuous life of big city nursing administration. Now, she said, every day, 24 hours a day, I staff. A scramble for nurses in hospitals that are empty but saturated. That's what Houston's version of a New York situation looks like. Ultimately, in a hospital, the fight against the pandemic depends on individuals. The same is true at the state level. Texas's governor, Greg Abbott, pursued a risky reopening plan until the surge in cases forced him to roll it back. Just before the July 4th weekend, in an about-face, he issued an order requiring nearly all adults in Texas to wear masks. He now faces a series of tough decisions. Texas has no income tax and depends on consumption taxes for revenue. With the state's cash reserves depleted and consumption locked down, Abbott must find a way to pay for enough testing and contact tracing to bring the virus under control. One option would be to expand Medicaid coverage, as Oklahoma has done. This would give safety net hospitals like mine increased access to federal funding. Abbott could also use resources more efficiently by declaring a state of emergency and asking the Catastrophic Medical Operations Center, a clearinghouse used during disasters, to distribute patients to ICUs. Right now, individual physicians must call multiple hospitals to find beds for their patients. Recently, in one of his regular pandemic update letters, James McDevitt, a dean at the Baylor College of Medicine, explained how the situation in Houston is evolving in ways that are both hopeful and disconcerting. Like many people, McDevitt wrote, he had been watching the virus's reproduction number, an estimate of how often any given case of the virus leads to more cases. When the reproduction number is greater than 1, the virus is spreading. If it's less than 1, the number stabilizes or even declines. In early July, widespread distancing and masking helped drive the number in Houston from nearly 2 to below 1. But July 4th marked an inflection point. After the holiday, which many celebrated in large groups with relaxed safety measures, the number has climbed again to 1.5, a level at which community spread grows more likely. Meanwhile, Houston hospitals have been seeing improved outcomes for COVID-19 patients. In April and May, those admitted to Baylor St. Luke's, a large hospital, stayed an average of 18 days, and nearly half were put on ventilators. Now, by contrast, the average length of stay has dropped to just only 5 days, and only around 14% of patients have needed mechanical ventilation. In part, we've been seeing younger patients, but hospitals are also adapting. Staffing changes are helping us squeeze more out of our strained capacity. Some new nurses recently arrived from out of state. And new treatment approaches, including proning and the use of high flow nasal cannulas, which deliver higher concentrations of oxygen without the need for intubation, have made a difference. Nurses, respiratory therapists, doctors, hospital administrators, and others are working to outrace the virus. Texas, in short, is expanding and retraining its medical army. And yet, in the absence of a vaccine or game-changing treatment, the only way to beat COVID-19 is to prevent it. In that sense, the troops that matter most are ordinary Texans, who alone have the power to decrease infections by maintaining distance and wearing masks. Houston is a medical city with more than 85 hospitals, but in this pandemic, its medical might is deceptive. No hospital system can cope with a virus this infectious without help from the people and their leaders. The only means of fighting a plague, Albert Camus wrote, is common decency. Thank you. I'm gonna take a sip of my Topo Chico here, which is one of the nice things about Zoom. You get topos that are cold from the refrigerator right there. So,
well, we'll give you I guess a silent applause. I think everyone are on mute. Okay, questions.
I could start out with one.
Sure.
Hi, I'm Leonard. I've read some of your other articles, like Poor and Uninsured in Texas and Where Will the Medical Misfits Go?
Yeah.
And you expanded on Ben Taub as a safety net hospital in those articles. My question is, how do you think COVID-19 has affected the medical treatment of the uninsured?
I think that's a great question. So in some ways, COVID-19 has paused the necessary care that people who don't have COVID-19 ought to be getting, because people are less likely to go to the hospital. The clinics have had restrictions, so much of the care occurs not just in the hospital, but in the clinics that are connected to the hospital. I think that the uninsured are a bit, I don't want to speak for everybody, but I think in my experiences, I've seen that some uninsured people are also wary of going to the hospital when there's many patients with COVID, and also increasingly knowing that bills and costs will be an issue, because even though there have been proposals for how to pay for hospital care with COVID, that has not necessarily panned out. So I would say that the safety net system in Houston has been working on overdrive to try to address the healthcare needs of people in Houston, and that was pre-COVID. Now with COVID, it's just like everything, it has slowed down. And so some people are really, I think, feeling that. I think that they feel that the slow, they feel how, there's not elective procedures, as many of elective procedures. And some of those are very necessary, but they're elective. So all of those things have slowed down. And so that has brought a big challenge to people who have chronic health conditions and who are uninsured.
Thank you. Another question?
I guess, one of the things that we wanted to say about this month of thinking about plagues and pandemics was we wanted something, at least I was saying this, I wanted the Honors College to make available to folks a perspective that wasn't easily to be found on our screens, whether they be CNN or Fox or anything in between. And so I'm wondering if you have some perspectives, impressions about we who are not on the front lines, who are not seeing what's really going on, that you would like to share with us, and be very pleased if you could do that for us.
Hey, that's something that I've talked with so many different colleagues about, and how medicine in so many ways is about nuance, and how our world, especially in the pandemic, has made nuance, has obfuscated nuance, or has erased it, so that there are poles, you know, and you have to fit into one of those poles. And you know, I think what I think and what I tell most people is that if anybody has like extremely strong opinions about COVID or about things, is that like, then they don't know what's going on, because all of these are challenging questions. You can't just have like, for instance, let's talk about children going to school. There's differing reasonable opinions on either side. So anybody who's extreme about one position on that, saying, you know, oh, we cannot under any sort, you know, we cannot have children going back to school, versus, and the other person is like, they must go back to school. I mean, you have to think of it's a very difficult subject to dissect, because there are pluses and minuses, and that's how medicine is. Medicine, you have to weigh risks and benefits for every treatment, and some treatments you have to you must contextualize those treatments and those studies for every single individual. Each person has a different way of responding. It has different risks with treatments. And so I think it's contingent on us to be thoughtful of that and nuanced in our approach to that, and not think about saying that there is one, you know, one size fits all. Now, certainly, you know, there are some questions that are, you know, I think that are reasonably like tipped toward one side. I think it's reasonable to say, you know, masks in general are very helpful to preventing transmission, and as a society we all need to engage this. And so, but for some people there are risks for masks, and that has to be weighed. So I guess what I'm trying to say is that it's been kind of frustrating to see sometimes that these core issues can so easily be made into extreme positions, rather than to be delving into the nuances of these. I prefer dissecting and thinking about the nuances of these issues, and seeing the common ground. So.
Thank you. Okay, Christiana, I'm gonna ask your question for you. This is in the chat, Dr. Nuila. So how do healthcare workers enforce quarantine or isolation on patients who pose a risk to others but won't voluntarily adhere to isolation?
That's a very difficult, it depends. It really depends. There are patients, people who refuse to have COVID testing. There are people who refuse to wear masks in the hospital. Healthcare workers can't really enforce that other than in specific circumstances. If that person is a direct risk to somebody else. So for instance, if that person is known to have COVID-19 and is sick and is attempting to cough on somebody, that is considered an act of violence. So that would apply under laws that restrict violence. But there's many people where it's not known and there's no enforcement. There can be no enforcement. There's and I mean this in the best possible way, but there's diplomacy. How do healthcare workers do it? You are diplomatic. You talk with people. You see why that is the case. You understand what are the options. Maybe we can move this person to a isolation bed where if they or if they refuse to go to an isolation bed, is there like a certain place where the risks are less? So so it all depends. It's very much like a case by case basis that you evaluate them.
Okay, thank you. Kimberly, would you like to ask your question? Great.
I was just commenting on how you're so correct that so many other people are so involved in healthcare, between social workers and nurse administrators and nurses and respiratory therapists. So I wanted to commend you for acknowledging that in our health and healthcare system. But also, I was curious, what do you think may be some of the longer term sequelae of COVID-19 with patients not coming in for preventative care or seeking care even for other acute issues because of their fear of coming into a hospital or a clinic setting with the potential of getting COVID? I just wanted your thoughts on that.
Well, I mean, there's a lot of potential sequelae. I mean, I think that we in Harris County and maybe nationwide have seen a glimpse of that question with regard to a certain type of patients who are undocumented, for instance. And what I mean to say is that when some patients who are undocumented and sick and very ill and they need treatment, when they feel like their lives are at risk, when they feel that the legal system is pursuing them, if they feel that their stay in this country is at risk, they often don't go to the hospital. And what we see sequelae wise in that with those people is that oftentimes they do end up coming into the hospital but sicker. One example is people who are undocumented and need dialysis. There was a study performed in 2007 here in Texas at Ben Taub that showed that when people didn't go to the hospital for treatment, they needed dialysis, they ended up getting more treatment through ICUs, and it cost the system much more than if people were going regularly to get dialysis treatment. And I think that dialysis is a very specific example, but I think that is a glimpse into this. It can tell us a lot about what delayed care can do. It tells us that because at the end of the day, symptoms, not all symptoms, but some symptoms will always drive somebody to the hospital. If you're breathless, you're gonna go to the hospital. Now, it makes a difference if you're breathless, like you are coughing a little bit and you can recover your breath, or you're just always out of breath. Now, the person who is always out of breath tends to require more treatment and can end up being in the ICU. That's not good for anybody. That's not good for that person. That's not good for that person's neighbors, because what that ends up doing is increasing the cost of care for that person. And it also creates backlogs, right? Because again, like from the article, there's ICU, there's different level gradations of people who are trained to take care of like higher intensity needs. So that's one of the concerns, is that there's not, is that, you know, the fear of going into the hospital, COVID-19, everything being paused. I mean, I think we're all feeling COVID-19 is just made everything slower, right? In some way, in many different ways. It's just like getting responses from people on, you know, through businesses, you know, whatever. It's just everything's going slower, and the same is going on in healthcare. It's slower, but when it comes to healthcare, those pauses, that going slower can mean that those people are sicker at the end of the day, and that in a system that's already overloaded and overburdened can create big problems.
So we have two questions that kind of counter each other. They're kind of interesting. Griffin, mask exemptions are quite a polarizing topic, and even the CDC guidance advising against in cases of trouble breathing is quite vague. You mentioned there may be some valid reasons for not wearing a mask. Can you paint in some nuance of medical conditions which would legitimately counterindicate use of a mask?
It's tough. I mean, I can imagine somebody who has very advanced COPD requiring oxygen, where they must. So COPD is an illness that is really about trying to get carbon dioxide out of the body, and the lungs aren't able to squeeze the carbon dioxide out. So carbon dioxide stays in there, it becomes acidic in your blood. And so I can see, if you have very advanced COPD, trying to squeeze that, you don't want any restrictions to be able to like squeeze that carbon dioxide out of your mouth, right? I can understand that, and I think that that's why I think that there are guidelines, and I think guidelines are a good start. But I think that case by case under applications of that is different than guidelines, and I could see myself seeing some of my patients who have advanced COPD and saying, well, you know what, maybe try to avoid those places where you really need masks, because maybe the mask is not the best thing for you, you know, and those are people who have advanced COPD who really don't want to have, you know, they're at risk for COVID. So you would advise them not even to go out in public very much anyway. But that's where I would that's one example of of where like the risks of a mask could be. Now, again, I don't want this to sound like there's so many different gradations of COPD, and I'm just saying somebody with very advanced, I can see one example of that, you know?
Okay, good, thank you. Amaris, would you like to ask your question? I think this is a really good question based on the last question.
Hi, I really enjoyed your talk. So there were, I'm just going to read my question. Recently, there have been a lot of concerns that this pandemic is being politicized, specifically in Trump's administration taking over the CDC and intention to issue an emergency use authorization to put out a vaccine against the coronavirus before the end of phase 3 clinical trials. An NBC article actually came out talking about that, which kind of concerned me. So what would you say regarding the hesitation of people from adhering to CDC guidelines in the future?
That is a really great question, Amaris. I appreciate that question. I don't know if I'm going to be able to answer it well, because I can tell you that I have, all I can say is that, like, I read those articles thoroughly, and I try to understand, and I try to juxtapose that against like other sort of articles, and I try to gain a perspective that's my own after reading different sides to things. And it is true. I think that, you know, I've had concerns that the CDC has, you know, it seems like before the pandemic, or before 2016, one could say that it seemed that the CDC was was not as politicized. Now, I think it's a little bit naive to think that it's never been politicized, but I think it's a little bit more overtly, like maybe like they're not giving objective data here, and there's, you know, objective studies. I don't have a great answer for that other than to think it through. I think that I'm glad we live in a democracy where there are people investigating this and speaking about this, and I'm glad that we can hear these voices very much, and that each person can sit through it. And I mean, not to be too transparent and give a plug to the Honors College, but that's why y'all are here, is to be able to like have the tools to read these articles, to understand what's going on, and to like dissect them, and to say, okay, this makes sense, but this doesn't make sense, and this is why I believe this article over that article, and this is why I think that maybe the CDC might be doing this, or maybe I don't think the CDC. It's up to the person, and I think education is essential to that. So I wish I had a better answer. I am concerned. I think I don't have like, you know, I don't have a knee-jerk response to say CDC, you know, I think it's a case-by-case evaluation of everything that they're saying.
Good, thank you. We have you can just cut us off when you're ready. Marina, let's see. Oh, Marina, okay. Thank you. I really enjoyed the discussion on the role of nurses. You guys could actually talk and say this, but now that you've written all of this, I feel like specifically in the medical field, there's a concept of hierarchy when really every single person in the medical field is essential to create a support system. How do you think this realization about the role of nurses and respiratory therapists, et cetera, will influence the relationship between the different medical fields?
I think that's a good question, and all I can say is that I guess you get to feel the importance of the team in COVID, because, like I said in the article, it was the nurses and respiratory therapists that deserve so much of the victory. And I really don't mean to exclude anybody. Social workers, sitters. It's all the best. To me, medicine works best when it is working as a team. Healthcare works best when and for teams to work well, different people are doing jobs and they're all communicating well. And so I hope that this realization pushes little things. And I mean this, I don't mean to use the term little, because I think this is a big thing really, but I can see how somebody might not think that this is a big thing. But for instance, like we should all be rounding together all the time, nurses, social workers, and we're starting to do that more, you know. I think that, I hope that this pushes more team-based, you know, encounters like rounding and things like that. So I think that there is more sort of understanding about how important the team is to success, and we're getting away from that hierarchy that you talked about, which is that the doctors are. I mean, I think maybe I'm too optimistic, but I feel like we're getting away from them.
Okay, thank you. So Carrie has a great Honors College-esque question. Carrie, can you ask your question?
Hi, yes, hold on, sorry. Let me go to my room.
No problem.
Dog's barking. I'm so sorry.
That's okay.
No worries, that's fine.
Oh my gosh, okay. Sorry, it's his 3rd month birthday thing. So we made him a cake. Okay, yeah, so I'm from the Rio Grande Valley. So I live in McAllen, and that's like a really big like COVID hotspot, and my parents both work in the health field. I wanted to ask if you think that individualism in American culture, our cases haven't been able to go down compared to countries whose cultures like are rooted in like community.
And collectivism is her last.
Yeah.
Okay.
I think that's
We can't live in fear forever, and I want to enjoy my summer, but there are people risking their lives trying to get rid of the virus?
I think that's such a great question. It is a very honors college. I'm glad it wasn't about Beowulf, your question, that it was honors college, but it wasn't about Grendel and Beowulf, but it is a very honors college. And I promise you, I've been texting my friends about this thing. I mean, okay, I want to contextualize this. It was in response to one thing that happened in an article, but at one point I texted too much freedom in America. And we have to struggle with that, right? We have to understand the pluses and the minuses, the risks and the benefits of our model of governance versus maybe other collectively minded ones. I mean, let's compare to China. And again, this is a very kind of like superficial comparison, but you know, in China, perhaps there is very likely more adherence to masks because it's imposed by a central government, right? And there's more consequences if you don't. There's less freedoms. But one of the minuses is that for those methods that the government uses, there's probably less voices to speak out against that because there's less democracy, right? So there's constant weighing of things, right? It's constant, there's no perfect order. It's just different styles and we have to, and there are circumstances, and some of those circumstances bring out some of the best and bring out some of the worst. I think some of the freedoms that we've had in America have been, you know, COVID has you know, COVID is at its state right now because of some of the freedoms we have. You know, we've enjoyed good times because of those freedoms too. So I do think that it's possible that in more collectively oriented like societies that control of something like COVID is a bit more possible, but you have to weigh the differences. And you know, I don't want to just draw any sort of like value judgment on that to say like, okay, we all got to move to China or we all got to move to like Bulgaria or anything like that. You know, it's just it's more kind of like taking like, can we make it a recipe? Maybe we live in America and we take a little bit more of a collectivism, and how do we amp up that collectivism so that we retain some freedom, and we retain the good things that our freedom brings, like expression, which I am really a huge, you know, proponent of, but how do we do it in a way that is not putting too many other people at risk? So that I like that method of kind of looking at it more.
We probably have about time for a couple more questions. I'm going to go to Samir, since you got a nod over there, Samir. And you can ask your question, Samir.
Sure. First of all, thank you for talking. It was really interesting to hear. So my question is, you know, at the beginning of the pandemic, and even now when there's not a lot of research to kind of sift through and guidelines to sift through, did you ever feel out of control or uncertain as a provider? Because I know in medicine, from my experiences with it, there's this perception that, you know, as a physician, you're able to fix the problems in front of you. And so I wanted to know how that affected you, how that affected your feelings, and maybe how that affected the way that you treated people or just interacted with the patients when they asked you questions.
I think that's a really great question, and it's really bringing me back. Thank you for that question. You know, did I ever feel? Yeah, certainly. Like I think one of the marquee sort of words that COVID brings to mind is uncertainty, and in medicine, uncertainty. I feel like different people have different ways of handling uncertainty. And I think medicine in general is not very good with uncertainty, even though I think that I think that you can make uncertainty your friend, and that's a different story. But I I think my feelings were also were more about my colleagues than about patients. I felt, yes, it wasn't clear how contagious it was, but we had a little bit of data. And I mean, I don't mean this to say, I just kind of look at, I'm the type of person who learns as little about patients before going to talk with the patient. I want to hear what are the problems from the patient's own mouth. And and so that process is just replicated, and it's just about like, so that's to say that I that's just the way that I have like done things and think and conceive of medicine is that I just like, there's reasons for that. I don't want the bias of other doctors. I think that it's more efficient, but I like to go straight to the patient and have a conversation. And so that kind of continued. There was a little bit more precautions I took. I mean, I did not like PPE to interfere between me and the patient, because I feel like I communicate with a handshake. I understand why we don't have it. I give elbow bumps now, and that's getting its own sort of thing. But it's like, I really enjoyed handshaking patients because I feel like that communicates something. But we had to stop that. I had to put on gowns. One of the other essays that I wrote, like I highlighted how I apologize to a patient for wearing a gown, because I don't like the signals that it necessarily sends, but I understand it, and it's necessary, you know? So what I didn't like is just that among some of my colleagues, there was just so many divergent levels of like, of this uncertainty and their response to this uncertainty of like, like what gear they would wear, and just forgetting that it's about like a conversation with a patient. That's like the core of this, of what medicine is. So I don't know if I answered your question, but my feelings were that I wanted to get back to what was normal, which was normal for me was just sitting at a bedside and talking with a patient and like thinking through problems, and COVID, and we had to get through that, and it's still not back to where it has been, but that's how I felt about that.
Thank you so much. Amazing. Okay. There are a couple of questions on the vaccine. If you could just speak to how you feel about, the vaccine, will it be ready by November 3rd? Does that even make sense? Should we take it if it's ready to go? I guess you have to take it. There are questions about whether people like you in the medical field, how often you get tested for COVID, et cetera. So a couple of questions, just kind of basic questions like those.
So, I mean, I've had COVID. I don't know how I got it. It's possible I had it. I think it's less likely I got it from one of my patients. I think it's more likely I got it in the community because it was high prevalence, even though I used masks and social distancing. That's how high the prevalence rate, and that just tells you why it's important to utilize those methods to keep everybody's levels down, right? So that people are less likely to get it. And I think that the vaccine is a very good way to do that, is to keep levels down. And when enough, herd immunity is when enough people have had it or have antibodies that it can't really spread. There's not enough people, there's not enough bodies for it to spread. And I think that the big question about, I know that everything's politicized and whatnot. I think the big thing about the vaccine, though, is that like we're not going to see the effects of it for many months. And it's one thing to have a vaccine. It's another thing for enough people to accept the vaccine in order to achieve that herd immunity, to achieve as a community enough people having had it and enough people immune to it that it can't spread. And again, we live in, maybe it was in this context that I said too much freedom, and that was the doctor side of me talking when I said, when I was thinking about people saying that they won't take the vaccine. Now, I really believe that we should make sure that it's safe. I think that the current vaccination schedule by the CDC is safe, the one that is administered to children. And I think there's data to show that, and I hope the same level of data is there for the COVID vaccine when it comes. Whether it happens in November, December next year, I honestly think it's just, I think it's going to happen. I think we're going to have a vaccine. I don't think that there's much doubt about that. So, but I don't think we're going to see the effects in November. We're not going to see like that it plummets, because that the infection rate plummets because first of all, it has to be given to a good amount of people, and second of all, people have to accept it, and that's being debated right now. So I think I got some of those questions in there, right? Hit on some. There was like 6 of them.
I know. I tried to rapid fire right there.
I think I got 4 at least. So I'm proud of myself right there. So.
Okay. Well, there are so many other questions, but we have to stop now, guys. I appreciate your engagement and questions, and let's try to take off the mute and give Dr. Ricardo Nuila a big hand to show our appreciation. All right, let's do that. We can hear it. All right.
The unmuted applause. I like that very, very much.
we're gonna.
Thank you all so much. That's very.
Will you come teach with us again?
I know.
I will. Hey, will you finish the book that I'm writing? Then I'll
Hey, send me the drafts. Maybe. I feel like we're living in the exact same zone, and yeah, absolutely. Okay, that's my dog.
Yeah, that's our cue. That's our cue. All right, thank you so much, Ricardo. So good to see you. Stay well, okay?
Thank you very much. Thank you all for inviting me. Thank you, Bill. It's always a pleasure. And to the Honors College students, I love the Honors College. You'll have such a good opportunity for education. Take it full advantage of it. Even read Beowulf. I know that's sacrilege to some people, and I don't mean to pick on Beowulf, but no, I was really happy to spend this time with y'all. Wonderful questions. Loved the questions.
Excellent questions.
Great discussion.
And look to the chat, Ricardo, and you'll see all the issues coming in. There was a great discussion. Thank you so much.
Thank you all very much.
All right. Have a good evening, everyone.
Hi.
Take care. Bye-bye.
Bye.